Hello viewers, welcome to another edition of Health Reports. I remain Moji Makanjuola and hope you're keeping healthy. Well, we're going back to that subject that we thought, we shouldn't talk about after a while. We thought Nigeria had actually overcome infections, but we still have it with us. I'm talking about HIV. We're here today on this edition of the program to speak about HIV, the current status of the epidemic, the treatment, and of course individual responsibility that are needed to stem the tide, because reports still reaching us says that Nigeria has the second largest HIV epidemic, so we still must speak to HIV. Now, it's not a death sentence according to the experts, but more and more people are still dying from HIV in Nigeria. Why is this so? So we'll examine all the ramifications around HIV, and I do hope that this program today will stem the tide and reduce infection of HIV in Nigeria. Welcome. This is Health Reports. We'll be back in a moment. This is Health Reports on Nigerian Television Authority, and on this edition we are looking at HIV, the current status in Nigeria, and how best to stem the tide, particularly mother-to-child transmission, and of course the vulnerable group, the youths that today are posting more and more infections. Now, to discuss this with me, I have in the studio Dr. Sani Aliyu, who is the Director General of NACA. That's the national agency that is responsible for the control of HIV and AIDS in the country. Dr. Aliyu, you're welcome on Health Reports. It's your first time, really.
Absolutely. I'm very pleased to be here, Moji.
All right. Yes. Well, we do know that for now, Nigeria still posts as the second largest HIV epidemic in the country, in spite of all that we thought, creating awareness and putting people on treatment. More and more people are dying. How would you explain the status of HIV today in Nigeria?
We estimate up close to a little more than 3 million Nigerians have HIV, which means that we have the second largest burden in the world after South Africa. So that's about 3%. In fact, on average, about 700 Nigerians catch HIV every day, and 500 Nigerians die from the disease. This is obviously a significant problem health-wise. It's a huge challenge to our health system. But we're doing a lot to get on top of it. So I can tell you, hopefully, in the next few days to a week, we might have the first million on treatment. We're now close to a million. About 970 to 980,000 people are currently on treatment, most of which is really sponsored by external donors, the U.S. government.
Actually, that's where I was going to go to. That how sustainable is the treatment for people who are on it now? Because well, we do have most of it are external donor. What are we doing as a country to sustain those, particularly those on treatment? Because once you're on treatment for life.
So as government, we are committed. If we do a HIV test on a patient and we put the patient on treatment, we are committed on keeping the patient on treatment. It costs about 50,000 naira per patient per year. It's obviously a lot of money. And about 700,000 Nigerians are on treatment courtesy of the US government through their program called PEPFAR. Then we have about 200,000 under the Global Fund, and 64,000 at the moment through the Taraba and Abia project that the government of Nigeria is funding. I think at 50,000 naira, it's still, yes, it's expensive, but it's not unaffordable for government. And government has been looking at different ways of trying to fund the HIV response, because obviously there are other national priorities that we are currently competing for resources. We've been working quite closely with the executive as well as the legislature through our House committees on AIDS, TB and malaria, and the Chair Senate committee we have. And I think the political will is there. It's really a case of identifying the resources and putting them where they are supposed to be. There are a lot of initiatives that we are trying to put into place, such as engaging with the National Health Insurance Scheme to have a community health insurance scheme, which I think in the long run is probably what will solve the never-ending problem of seeking resources. And we are also looking at reducing the cost of delivering HIV care. So, for instance, that 50,000, if we can bring it down to 30,000, a lot of states will probably be able to take up the HIV response, maybe by trying to get the antiretrovirals produced locally in Nigeria.
I was going to go to that. Are you speaking or are you engaging with the pharmaceutical industry? Because at some point you said that if we could manufacture the ARTs in Nigeria, we'd go, of course, would go a lot cheaper. And well, India has the generics and they're using
India
that.
Has the generics. In fact, India has been partnering quite closely with a Nigerian company. One of the large Indian generics, Malan Laboratories, has been talking to a Nigerian entity in Lagos. And we really hope in the next year or so, the first antiretrovirals will be produced in Nigeria. Antiretrovirals are drugs that are used to treat HIV. And these will be the same drugs that we currently buy from India. Virtually most of our antiretrovirals are brought in as generics, because we need the cheaper versions in order to be able to afford them. But there are other initiatives as well. So one of the biggest challenges when it comes to the HIV response are the commodities. They are the big sort of budget item. And in fact, if you look at 2016, our partners spent $155 million US just bringing in commodities into Nigeria. So the drugs themselves, the laboratory reagents, and the test kits. Nigeria spent about $1.5 million US, so which means that 99% of the commodities coming into the country are donated. And we have to break that cycle. We really have to. And we've had meetings with the very top executives. Last week we met with the acting president, and he was very much understandable and very much keen to help us to break this cycle. We are looking at engaging the private sector as well. We're trying to create a HIV fund, which will be used principally to buy commodities, because if we can bridge that gap in commodities, then if you look at clinics and services, they are already being provided by government. If you go to the state government hospitals, you have hypertensive clinic, diabetic clinics. So that infrastructure is already there. The staff are already there. What you need is the training and the commodities. And that's what we are really pushing for.
Well, okay. Well, even if we have it, and how do we? Well, we still need, I believe, aggressive advocacy to get people to voluntarily go for testing, because if you don't test in good time, well, we know the consequences.
Yes, indeed. Moji, I'm sure those of us that are slightly older, our generation, for instance, we've grown up knowing that HIV is a major health problem, and our generation have taken precautions to make sure that we remain healthy and free of HIV. But the younger generation, I wouldn't say it's the same. A lot of the new infections we are getting in the adolescent and young people group, particularly in young women between the ages of 15 to 24 years. Some of them catch HIV with their first encounter. And before they've even heard of the word HIV/AIDS, they've got the disease. So What that really needs is a very good intensive media advocacy. A lot of adverts, because nowadays you don't see the sort of adverts we used to have on TV many years ago. You don't see the posters.
It's a bit quiet. It's
a bit quiet, and we're trying to change that at the moment. We have been working with some of our partners like FHI 360 and part of the US government-sponsored programs to make sure that that message goes out. And another key message that I believe is still not very clear out there is the issue of prevention of mother-to-child transmission.
Transmission.
Yeah.
Just before we go to that, because that in itself, it's important. I'm worried about the vulnerable group that are that are coming down with infections. Those are the youths, particularly at the rural areas. How best to stem the tide, because these, like you just said to me, and that's worrisome, that some their very first encounter, and here's a country that we're not particularly open about sexuality even now.
We have to discuss sex. I mean, yes, it's an issue that people tend to shy away from, but you can only protect yourself if you have the knowledge. If you have the knowledge on how to protect yourself. We've opened youth centers in the last few years in some of our universities. A lot of our HIV tests are currently done outside the normal hospital setup in order to encourage young people to attend. And we've also involved media people, especially from the sort of film industry side, to put out those messages. And we're putting out a lot of radio jingles as well. But it's all about awareness. HIV needs to be in front of your mind if you really want to remain HIV free. You need to remember all the time when you're engaging in activity that there is always a risk, and you've got to protect yourself.
Maybe we need to remind our viewers about the risks, because people really just forget. I mean, people are not dying, and you don't see skeletons around, living skeletons as they were, when HIV came to force. So maybe you need to remind our viewers of the risks that you are if you are exposed to these actions, and you might come down with HIV infection.
So obviously most of the transmissions in Nigeria are heterosexual, so that's male to female or female to male. And this can be stopped simply by using barrier methods such as condoms and of course abstinence. A very small proportion will be due to blood products, but nowadays that's not very common, because most of the time, if you're having blood transfusions, a HIV test will be done before the blood is given. And then, of course, you have certain groups like injection drug users that can transmit HIV. In Nigeria, fortunately, the rate of transmission from injection drug users is extremely low. It's unlike in other parts of the world where it's a major driver for HIV infection. So those are the sort of three key routes. And then we have, of course, from mother to child. And from mother to child, that's a crucial bit that really worries us, because we estimate about 60,000 Nigerian babies are being born every year with HIV. That's 5,000 a month. And for a condition that's actually, you can actually eliminate. There are countries in the world that have completely eliminated mother-to-child transmission. I think it's not fair to the child.
It's not fair
to the child. And when we talk about an AIDS-free generation by 2030, you can only achieve an AIDS-free generation if you eliminate mother-to-child transmission, as well as eliminating transmission among adults.
Maybe again we need to explain to our viewers why. I mean, you've said. I mean, it's mind-boggling to know that such huge number of babies potentially, at risk of HIV being transmitted to them from their mothers. What exactly? Maybe we need to take our mothers through the fact that you can't. Well, if you're HIV positive yourself and you need to have babies, these are what you should do, and to ensure that you do not expose your child to the infection.
So the good news is if you have HIV infection and you take the drug consistently, the antiretrovirals, the amount of virus in your bloodstream goes down to very low levels, such that transmission doesn't happen. So in a mother, for instance, has about a 30% risk of transmitting HIV to her baby without the drug, if she's not virologically suppressed. Once she takes the drug consistently and it's undetectable, in the first place, we don't even do cesarean section anymore to prevent HIV. She can have a normal birth, and she can even breastfeed, provided she continues to be virologically suppressed. It goes down from 30% to less than 1%. In certain parts of the world, so the UK, for instance, where I've practiced for many years, if any of my patients gets an infected baby, I'm in trouble, because it means I have failed in my duty to make sure that the mother, that the baby is protected. It means I have failed. And seriously, what we need is HIV tests routinely among pregnant women. There's a lot of debate from the public health side as to whether is it cost effective, but that's the right thing to do. That's the international standard. Yeah, anywhere you go in the world, a lot of places, if a woman is pregnant, she will have a test for HIV, she will have a test for hepatitis B, she will have, in the UK, she will have a rubella antibody test. There are certain infections that are so important that you need to prevent them. You need to prevent the child from picking up those infections, and there are ways of preventing them.
And we have those ways here in Nigeria.
Oh yes.
Yes.
So we have, I believe we have, out of the 170,000 pregnant women with HIV, we have about 50-something thousand, currently 54,000 or so on treatment. That's about 1 in 3. But that puts us right at the very bottom of the list of countries when it comes to covering preventing mother-to-child transmission. It's a list that Nigeria is at the very end. We are at the very end of that list. And it's...
So how do we obtain this? Because it's important.
It's important.
Yeah.
Again, awareness. Awareness is the first thing. Are you pregnant? If you are pregnant, the next thing is you need to know your HIV status. You need to know your HIV status for your own health and for the health of your baby. You don't want to have a child born with HIV. You're committing that child to medications for life. For life.
Yeah, I was going to go to treating children with HIV. What's the status in Nigeria? Are we having more children survive on it? And what really,
the survival curve has improved across all age groups. There are challenges with children, obviously, because you need liquid formulations for a child who cannot really understand why you're giving him or her medication every day. It's very difficult. And as they grow older as well, and they go into their adolescence, the turbulent years, they tend to be also more challenging when it comes to treatment. So yes, I completely agree with you. It's more difficult treating a child. But then it's the more reason why that child should be free of HIV. Yeah.
And it's possible.
Oh, it is. It is. And it's got to be done. It is not fair. It is not right. We shouldn't be allowing our children to be born with HIV when we can do something about it. And that message is being pushed out loud and clear by ourselves and by our partners as well. Yeah,
thank you. This is very reassuring. Again, I think this is one point that we need to echo on all the time. And again, the controversy of breast feeding, which you just said as a matter of fact. I would like you to emphasize on that.
So if you have HIV and you're not virologically suppressed, you shouldn't breastfeed your child.
How do you know?
So if you have HIV and you're not on treatment, the likelihood is you will have a viremia. That means a detectable virus in your bloodstream. But on average, it takes about 6 months to go from having virus in the bloodstream to an undetectable or very low level of viremia by taking drugs. Drugs are the only thing that will get you virologically suppressed. Okay. Yeah. And once you're virologically suppressed, the body fluids do not contain enough virus for the infection to be transmitted. In fact, there are studies in the world that have shown once you reach a certain level of epidemic control, so 80-85% of your entire HIV population are on HIV treatment and they have undetectable levels, the transmission stops, the epidemic stops. It goes down on its own. And it's probably one of the main reasons why in Nigeria the prevalence has been going down. It's because we are having more and more and more people on treatment. We are just about to cross the 1 million mark. We still have about 2 million people possibly with the infection, but we are slowly getting there, and we are already seeing the impact of that in terms of the epidemiology.
Yep.
So treatment is not just for the individual patient, it's also for the public good, which is another reason why we have to commit those resources to manage our HIV response. We can't leave it to just our
When we're
partners.
talking about response, what are the main challenges in reaching out? Because well, with what you've said, I know that we're looking at getting as many more people on treatment, needing treatment. Maybe first you want to clarify that not everybody needs treatment, so but those who need treatment must be on treatment, and treatment is for life.
Yes.
Now, what are the gaps there?
In fact, Moji, things have changed, I'm afraid. So nowadays, when we diagnose HIV, patients go straight on treatment.
Oh, really?
Yeah. Oh, yes.
Every
Patient with HIV.
that's
why?
huge.
Oh, that's huge, and that's why the numbers have gone up. We call it a test and treat approach. And that's because over the years we've realized that if we wait until your immune system goes down to a certain level, A, it might be too late, B, the issues in terms of outcomes, clearly it's been shown that you're less likely to pick up things like tuberculosis. If you're started early on treatment, the overall outcome is much better before your immune system has gone down, because in some people, immune recovery actually may not happen completely, and the risk of other diseases such as cancers also goes down with early treatment. So nowadays, HIV test done, positive, you go straight on to treatment. The only situation where we don't start people on treatment is where clearly they are not ready yet and they want to think about it. They want to take a few weeks to get their mind around the disease, in which case we'll give them a few weeks, but we will aim to start them as soon as possible. And across the board, whether it's a child or it's an adult. But that's what's really pushed the cost significantly. But it's still a cost that can be borne by the country. It will probably cost us about 150 billion naira to put everybody on treatment.
Because everybody needs treatment.
Everybody needs treatment. Everybody.
What states are more? Where do you have HIV prevalence?
So the data we have is still a few. We've had the data for some years. We are just about to start a population-based survey, which will once and for all answer that question for us. And our partners are committing a lot of resources towards this, and we're very grateful to our partners for understanding the reason why we feel we should really rebase our epidemic. But at the moment, if you look at the hotspots in the country, they're mostly around the Middle Belt area and the south part of the country. But of course, I'm wary of trying to say certain parts of the country have more HIV than others. Yes, that data is out there. If you check on the internet or on our website, it will clearly be there. There are some parts of the country that have a very low prevalence, and for those parts of the country, what we are doing is we are pushing the state governments to take more responsibility for HIV patients, because it's possible if you have just a few thousand, maybe 50,000 people with HIV, it should be possible as a state government to commit your resources to look after your patients, especially the pregnant ones.
As it is now, the federal government, with partners, do all the treatment. The states don't contribute at all, or they do?
They contribute very little. There are some states that have really helped the response. So like Kaduna, for instance, and Lagos, they have committed a lot of resources. But HIV is not a tertiary healthcare problem. It's not a problem of the federal government that the federal government needs to. The federal government needs to take the lead, and NACA with the Federal Ministry of Health, we are taking the lead. But at the end of the day, the financing really needs to come from the states. Constitutionally, it's their duty. It's not a tertiary healthcare problem. It's a primary/secondary healthcare problem.
And the states that have taken responsibility to intervene in treatment, for example, do you have less prevalence in states like that?
So prevalence takes a while to change.
Yeah,
it takes a while to change. So and a lot of
the
increase.
Survivals?
Oh, it's survival. There's no doubt about it. There's no doubt about it. A lot of people are alive today. hundreds of thousands of Nigerians are alive today because of HIV drugs. In fact, in the world, millions are still alive, they are healthy, they are breadwinners for their families because of the drugs that are available. And the drugs are not that difficult to take anymore. Initially, it used to be a cocktail of many tablets, that patients take, and it fills their stomach. They probably don't need to eat after that because the pills are so many. But now it's just a single pill taken once a day, and very tolerable as well.
And are we doing any research about any particular strain of HIV in Nigerians or in Africans that
So in Nigeria, the common strain is usually, it's a recombinant strain. We call them the CRFs, so common recombinant strain. But we do have subtypes as well that are available. I'm not aware of any huge change in the epidemiology of the strain of the virus, and certainly we have been monitoring with our partners. We've been monitoring resistance, which is another thing that worries us because of the amount of antiretrovirals that are being used in the country.
Our time is fast spent. Get my director warning me about our time. So before we go, what would be your main message? What would be your priority as DG NACA?
So I have three main messages to the public. The first one is HIV is still very much around. If you don't know your HIV status, please go and have a HIV test done. It's really important because it might save your life. Just because you have HIV doesn't mean that you have a deadly disease. Secondly, to our pregnant mothers, if you're pregnant, please make sure that you have a HIV test. It's really important for your baby. And then thirdly, just remind the public that we do have a line that's open, a telephone helpline. It's 6222. If you have any questions about HIV, whether it's where to go for a test, how we treat, or any information at all, or you just want to have a chat and you want to tell us more about your risks and where you should go for a test, get in touch with us. We'll be very happy to talk to you.
And I think most importantly, if you must have sex,
yes,
protect yourself. Yeah.
Thank you, Moji.
Thank you very much, Dr. Aliyu, for coming on Health Reports. And that's it, viewers, for this week's edition of the program. I do hope that you remain protected. That way we can actually stem the tide of HIV in Nigeria, particularly the transmission of HIV from mothers to children, and that way we'll have a healthy herd that will be involved in building our dream Nigeria. Thanks for watching. Health Reports will be back same time next week.